Once again, I would like to thank everyone for joining us this afternoon. My name is Victor McKenzie. I am the Executive Director of the Substance Abuse and Addiction Recovery Alliance. We are a statewide organization that advocates, educates, and support individuals and families affected by substance use disorder through the lens of recovery. I am joined today by Julie Funkhouser, who is the co-founder and CEO of the Recovery Connection. Dave Rook, who is the chairman of the Virginia Association of Recovery Residences, or VARR, and Jimmy Christmas, CEO and clinical director of River City Comprehensive Counseling Services. And we are gathered here today to talk about the need for transformative investment in recovery services here in Virginia. Just a while ago, through the Mercury, they released an article talking about the fatal drug overdoses here in Virginia. And in that article, they said Virginia is headed towards another record number of drug overdoses deaths, which experts blame on social isolation, stress associated with COVID-19 pandemic, and widespread trafficking of fentanyl and powerful synthetic opioids. And you'll hear more about that a little later. In addition, the medical examiner's office released a report. And in that report, it projects that about 2,620 Virginians will die from overdoses of fentanyl, cocaine, heroin, prescription opioids, and other drugs in 2022. That's a 13% increase from the previous year and comes right after a 42% increase in fatal overdoses from 2019 to 2020. So this thing is getting worse, and the need for those investments are now. And just to give some context to that, in 2010, that number was 690. So we went from 690 to 2,620 in a little over a decade. And so today we're just gathered with leaders in the recovery community who will talk about a few different ways in which we really need to improve our recovery services. And with that, I'm going to hand it over to Dave Rook. And just a bit of housekeeping, please keep your mics on mute while folks are talking. And if you have any questions, drop it in the chat. We will give some time for Q&A afterwards.
All right, thank you, Victor. Thank you to you and the SARRA Center for putting this on, and thanks for all the people that are watching. It's kind of a loose leaf type of thing where we're just gonna kind of throw some stuff out there and talk about some things informally, so to speak. But I am David Rook. I'm the CEO and co-founder of True Recovery RVA. We have about 186 recovery house beds across the metropolitan area. I am also the president of the board for the Virginia Association of Recovery Residences. I see a few of our board members and VARR staff here with us on the call today. So I'm sure I'll hear a lot about what I forgot to say when this is over with. But VARR was established in 2011 by several operators who thought that we needed to begin to self-regulate as more and more people came into the space. And we were a fledgling organization for many years. In 2018, 2017, 2018, we started to reestablish the board of VARR. And in 2019, we started partnering with the state for voluntary certification of recovery housing, which has driven a lot of I think, public confidence and maybe even some question at times about whatever, but it's driven public confidence in and around recovery housing. We work closely with Henrico County, the CSBs across the state, the Office of Recovery, and many other recovery organizations when it comes to housing individuals, placing individuals in housing, what the standards are, what that looks like. And what we found is that there's many great operators out there, both certified and uncertified. What we do is we bring a collective voice of standards, and we use the NAR standards, which are at their level 3.0, which means they're in the third version, so they're constantly evolving, and we're making progress on those standards as they grow. And people are allowed to have their own. I think one of the biggest fears is that we're going to come in and tell people how to run a program. And it's not like that at all with VARR. Everybody's allowed to have their individualism, run their programs generally how they see fit. What we're looking at is overarching ethical situations, safe reporting, and also stuff like fire extinguishers, Narcan, training, policies, procedures, and things like that. We'll make sure that those things are somewhat set across the board, that we meet a standard so that consumers can have confidence when they send their loved ones to us, or when somebody comes to us, that we meet a level of care. Now, one of the big misconceptions about recovery housing is that, when people say, I hear it all the time from CSBs, well, you don't transport them here, you don't transport them there, So with recovery housing, I think it's important, and we talked about this with the National Council of Behavioral Health recently. The setting oftentimes in a recovery house is the service. So that's important to remember. It's the setting is the service. And that's why standardization and making sure that we're doing things as a group and trying to build a family-like atmosphere, because that setting is the service. Now, many of us go above and beyond that setting as the service model and offer many other things. And it just varies from recovery house to recovery house. So it's important that when you're looking into recovery houses, whether you're making referrals or you're sending a loved one there, that you just do a little research, and you can call any of these organizations, you can talk to them, you can call the VARR office for descriptions more about what level 1, level 2, level 3, and level 4 recovery houses are. We have worked diligently to try to bring more funding into the recovery space. And so far, in the last 2 years, I think the total comes to somewhere around $10.75 million, into the recovery community space. We've been able to really offer for our membership, offer indigent bed money across the board. And there's some important things that come with that. Through that indigent money, right? Because most recovery housing in Virginia runs anywhere from $15 to $25 to $30 a day, which seems affordable to a lot of people, but that is a major barrier to some. So what we've been able to do with this indigent money that we've been able to bring in is we've really been able to tap into populations that previously couldn't afford even $20 a day. And it's allowed us not to take such a financial burden when trying to help those folks that didn't have the resources. VAR has gone, when we first started receiving the money, according to our best data that we had, we were serving about 80% white, 20% non-white. Over the last 2 years, we have shifted to 60% white, 40% non-white, which is a major thing. We also have been able to see that we use this assessment tool through the advanced recovery management system, and we've been able to look at people's scores, and we're getting people that have a much lower score because we're able to reach people who have greater barriers to recovery through this. So it's really been cool to watch and be a part of, and we're continuously trying to do that. Some of our other money is going to fund and help start more urban and minority owned recovery housing, because it is a little, it is a little heavy on one side. So we're trying to focus more on getting some more of that going on. We're also reaching out and really starting to start these major projects. We've got some major projects in Danville. We've got another one out in Russell County, which is way out there, in between Christiansburg and Bristol. So it's way out there, like Big Stone Gap area of Virginia. And so we're working with several groups to try to expand, get recovery housing and recovery centers opened up in those areas. Yeah, so that's it. We pushed for legislation this year. We had House Bill 277 that we've really been pushing through. And I appreciate those of you that are on this conference today that have supported us in that effort. And there was some confusion about it, but basically what we're saying is, look, the state wants a voluntary certification, and they need to help us incentivize what that certification looks like through limiting those that can receive referrals from people that are licensed or receive state funding, that they should only go to certified recovery housing, that we should have the right to, in these communities, a lot of the NIMBY groups, they talk about not having safety. So one of the things is when somebody starts using or drinking in a recovery house, one part of HB 277, it allows us to more easily use the police if necessary to have someone removed from our property to protect the neighborhood and to protect the other members of the house. And so we've just been, you know, really focused on that stuff this legislative session, and with our finger on the pulse for a lot of the other stuff that you guys, if you get the emails from SARRA Center, you're familiar with. They've really been doing a good job at pushing this stuff out this year and keeping us up to date on what's going on. So I think that you know, can capture kind of what we do, what we're about. And you know, open for questions when that time comes at the end of the conference. So Victor, thank you.
Thank you, David. And I mean, I thought you laid it out pretty plainly, the need for investment in recovery houses, especially with ease of access, removing some of those barriers and getting people into a setting that is primed and ready for recovery. That's needed. And thank you all for who have just joined us. We're going through and we're talking about the need for transformative investment and recovery services. If you're familiar with SARRA, we've been pushing our legislative priorities. Don't feel like you need to take notes. We'll send a wrap up with some of the bills that we're tracking, as well as some that Dave and Julie and Jimmy support. So we'll send all of that in a wrap up. But I really want you all to just pay attention to the words that each presenter is sharing. And with that, I want to hand it over to you, Julie.
Thank you, Victor. Thank you to Sarah, to Dave, to Jimmy, and to all of you that have shown up today. Really grateful for the opportunity to share with you just a little bit about myself, the Recovery Connection, Danny's Law, which has been a 3-year effort and still moving, and intend to touch on some important legislation regarding Medicaid peer reimbursement, demand for increase in those rates. So my name is Julie Funkhouser. I'm the CEO and co-founder of the Recovery Connection. We're out here in Winchester, Virginia. We are a Medicaid treatment provider. We have level 3.1 homes. And we also are VARR operators. We are level 2. We have 2 level 2s. Incredibly grateful for the partnership with VARR, working with Dave and Bob I saw on here, and Anthony. And so, you know, we actually on Monday, we're getting ready to open IOP and PHP to provide integrative services for our clients. So now, you know, we will soon be able to widen the continuum and better customize the unique needs of every individual that walks through our doors. And I couldn't be more grateful for the opportunity to serve the community and beyond, and grateful for all of you for your passion and commitment to the work. And, you know, we're all in this thing together. And so I'm grateful that, you know, Sarah has, you know, asked for us all to come together to discuss important pieces of legislation. And yeah, so also a little bit about me. 2 weeks after, not even 2 weeks after the Recovery Connection opened in September of 2018, I lost my husband, Danny, to an overdose. And, you know, I won't spend too much time, you know, in, you know, all of the specific events leading up to his passing. I will say, you know, the events leading up to that were indicative of significant gaps in our system related to crisis, related to emergency departments, the hospital systems, or the lack of policies and procedures, mandated requirements on ways that ERs can engage individuals when they are at their highest level of crisis, right? And so, you know, navigating the hospital systems has been quite the endeavor. And so I, you know, want to thank anyone on this call that has supported, advocated along the last 3 years for what has been very incremental progress, but it's been progress. So, you know, I was advised, like right in the beginning, I had no idea what I was doing. I had no idea how to advocate. I had no idea how anything worked. What I did know to do was to tell the truth and share my heart. And so we've got a little bit of movement along the way. And, you know, over the last 3 years, there has been bit by bit by bit incremental progress. And so just to share with you where we are now, last year's legislation, the win that came out of that was a working group that was developed through the Department of Health Professions that came together and met back in October to develop best practices for navigating opioid-related emergencies in the emergency departments. So from that, this year, HB 420 was dropped, and that was to mandate the adoption of those best practices. And so, you know, up until about a couple of days ago, everything was looking like it was moving right on through. There was an appropriation item of this to hire a full-time staff through the VDH to support the implementation across hospitals with this. I was notified that, unfortunately, that was killed in appropriations, which then everything, you know, connected to that is passed for the remainder of the session. What I will share, and I can share about this a little bit later, there was also a pilot program that was put into the mix that is separate and still alive, that would run out of Carilion Hospital and would essentially launch all of the best practices to, you know, identify any barriers or issues that may arise and how all of the hospitals could adopt. So, you know, more to come on that, and I can speak later, you know, on ways that we can come together to advocate to really push for this pilot program to launch this year. And, you know, I know it goes without saying, we're all here, you know, because we are passionate about the work specific to crisis intervention. You know, the data is that when somebody overdoses, they have now become at a 60% higher chance of overdosing again. In the emergency departments, I can't tell you the amount of times that I have heard stories or that someone overdosed, was revived with Narcan, taken to the hospital. You know, we've had instances where clients have come in and shared stories where they were just discharged without resources, referrals, engagement, introduction of buprenorphine as applicable, like just, there was nothing. And so, you know, typically, you know, codifying the standards of care is a real barrier through the hospital systems, but there is some things that have happened over the course of the last couple of years where standards of care have been codified. The co-prescribing of naloxone, right? That's a law right now. That's if somebody is prescribed a certain amount of opiates, they have to co-prescribe naloxone. So wouldn't it make sense that when somebody is overdosed, we dispense or distribute someone with Narcan upon discharge? So I will also share that as a Medicaid provider, this legislation related to the increase in Medicaid peer reimbursement rates is so important. We at TRC utilize peers. We know how impactful the utilization of peers, the engagement and support that it has, the positive impact. However, as a provider, a person in long-term recovery, I, as well as all of us, know the positive impact that it holds. As a Medicaid provider as well, the reimbursement rate to date does not provide much opportunity for me as an operator to navigate funding this role. And so this is vital to the expansion of access to care, you know, and so anything that any of us can do to help really continue to push this would be absolutely incredible. And we will see, I guarantee it, a huge increase in the employment of peers across different treatment providers. So I think that is all I have. I'm sure I missed a lot, but I am happy to share my email or, you know, anything and everything at the end of the call and answer any questions. So thank you again so much to Sarah and to Victor. Thank you, Dave and Jimmy. And yeah, let's keep rocking this stuff together.
Yeah, thank you, Julie. Wow, I think you covered a lot. So the idea that you missed something is wild.
I don't know. It's very fast moving, you know?
No, I mean, we all know who work in the space, how much work needs to be done and just how little time and how important it is that, you know, we're just timely with what we do and what we say. And so anybody who's been able to meet Julie or hear about her story knows the impact of really that advocacy with experience. And, you know, you mentioned two things that that really stood out was just the importance of a bill that we've been pushing, the Medicaid reimbursement rate. That would take the current rate of $6.50 per 15 minutes up to $19.50 per 15 minutes. And so you don't have to know anything but math to know that's a big increase. And it takes it from $2.70 up to $8.10 per 15 minutes for group work. And so you multiply that by 4 to get your hour, that's a huge increase. And that will allow organizations like Julie's, community service boards to hire qualified individuals with that lived experience that we know makes the difference, that we know has a positive impact, and to ensure that people who want to work in this space and share those experiences, that they're earning a livable wage, right? We can't ask you to come up, show up and show out and not be compensated, right? And so we realize the importance of that and the value of that. And that's why we've been pushing it. And we have one of our great partners, Heather Peck, on the, I see you up here. So I don't know if Becky's on, but I see you, Heather, who's been really wonderful in helping us push this. And so, yeah, I'll go at the end of the call to kind of list through some of our other legislative priorities. But right now, I do want to hand it over to Jimmy.
Greetings, everyone, and Victor and Sarah, thanks so much for hosting this event. Thanks to Julie and David for getting this started. And so I'm going to talk a little bit about recovery housing, treatment housing, and the barrier crime. I'm a licensed clinical social worker. I've been in this field since about 1994. I'm a person in long-term recovery. I got clean in 1992. I was very fortunate. I actually was one of those persons that was initially caught up in the whole barrier crime when it came around in the early 1990s. So it was pretty, it was a scare for me until the Department of Behavioral Health intervened and I realized that I was grandfathered in. But if not for the department and being grandfathered in, I probably would be one of those persons that still may not be able to work in this field. So the barrier crime is something I hold very near and dear to my heart. And thanks to Victor and a lot of other people on this call, you know, I'm going to be hopefully heading some of that initiative to really explore the barrier crime and hopefully put together some information and some bullet points that we can share with our legislators, the Department of Behavioral Health, and everyone else. You know, as a treatment professional, one of the things that I've been knowing, I've always been looking at service delivery gaps. And to me, recovery housing is that main organization, that main entity, that main function that fills the major service delivery gap that everybody looks for. I've been in this field, and whenever someone is leaving a hospital or leaving the Department of Corrections or jail or whatever, the first thing people are looking for is housing, and it's just so critical. Recovery housing is probably the only housing in Virginia or maybe in other places where it's on demand, that it's same day access. There are not many other programs, and I love and respect all the other great housing entities we have in Virginia, like Safe Harbor and all those places. But recovery housing really is that piece of housing that you can access immediately. And historically, they have taken almost anybody. They take the people that on paper, nobody else wants to take. And we still have those issues right now. And part of my quick spiel about this is that, you know, especially since all of us are in this space right now, is that we support and uphold each other in the community, because we never know who's listening to what we're saying. I know not too long ago, there was a Facebook rant about someone being discharged from a recovery house. And lots of people jumped on this Facebook rant and had their 2 bits to share about a specific recovery house, and then globalize, you know, what recovery houses do or don't do. And you know, if we really want to get this recovery-oriented system of care, and if we really believe in addiction recovery management services, this body, everybody that's on this thread, we need to support each other's organizations. You I've heard some things unflattering said about SARRA in the past, as well as everybody else. We have to support each other. It's no different. If something's going on with my company in River City, don't let that necessarily be a reflection of me. Call me up, because I am into continuous quality improvement. I want people to have the best experience when they're contacting River City. And I know that's true for SARRA. And I know that's true for David Rook, who runs True Recovery. I think I saw Anthony Grimes. I know this is the same for Julie. Is when you hear something about our organization, give us a call to really find out what's happening, so we can really make some efforts to put the client first, to right or wrong, and make things happen. What happens, we see these collateral consequences that occur when people just begin to have their opinions about what's going on. We can't afford that right now. I think in the first time in the history of, since I've been around and in this field, especially with the hard work that VARR's been doing, and other organizations like SAARA, Sarah Scarborough and her team at Real Life, we're seeing the recovery operators and treatment recovery organizations really gain a foothold and become respected in the community, and be seen as probably the centerpiece of recovery-oriented systems of care. And you're going to, whenever for any of you guys, if you want to hear me talk, I'm going to always talk about recovery-oriented systems of care. That just means that really, basically, there's this system, all of us are working together, and we're trying to make that warm handoff, that soft handoff, to make sure the clients get where they need to get. The Department of Behavioral Health uses this terminology. SAMHSA uses this terminology. I know Julie was talking about being a Medicaid provider, and DMAS actually uses this terminology. And some of the other organizations talking about addiction recovery management systems. Guys, that's what we're doing. We've been doing it for many years in a very unorganized way. But now here in Virginia, again, thanks to VARR and a lot of people I sit on the VARR board with and other private providers, we have made this very intentional commitment to really make this a reality. And it's harder than it seems, because there are quite a few players, but I know in the Central Virginia area, we're really piloting quite a bit of activities that helps people get to this point where they're abstaining and then moving towards the long-term recovery. One of the things that I'm pretty sure a lot of folks know is that what happens in historically, whether it's from our legislators and family members and even trained clinicians, we believe that the acute episode, the hospitalization, the treatment center, we believe that that's what helps people get and stay clean. No. That's just the episode that gets the person's attention. What helps the person get clean and stay clean is all of the support, all of the organizations and people working together to help move this person along so that they can get clean. Because remember, what we know about the disease of addiction is that it's a primary, chronic, progressive, and it can be fatal, and it's typified by multiple relapses. Okay, and by having a recovery-oriented system of care through the use of many types of addiction recovery management systems, whether that's the recovery housing that we've been talking about, whether that's treatment that Julie's been talking about, whether that's includes intensive outpatient, 3.1 clinically managed, 3.5 such as Pyramid, Pinnacle, and all these other organizations, whether it's traditional outpatient, and then bringing along peers. It's critical that we have a system and that it's reasonably organized in a way that we don't miss a beat in the process of helping clients move through the system. Okay. So again, that's about it for me. I look forward to working with a lot of you folks. And again, about the burial crimes, it's no rhyme or reason. There's been no evidence to support that people with criminal backgrounds are recidivized once they get clean and once they're getting in the field. I'm a prime example of it, and I know many other examples of individuals with criminal justice charges who have made good human service professionals. And Julie, it just doesn't affect peers. I know a lot of individuals who have gone back to school, gotten their bachelor's degree, gotten their master's degree, only to find out they can't work in this field that they love. Okay. So I look forward to working with SARRA, VARR, this body of work to really sink some teeth into the barrier crime bills, peer reimbursement, and build this true recovery-oriented system of care that can be a model for individuals outside of Virginia. Thanks for inviting me here today.
Absolutely. Thank you, Jamie. I think you touched a lot, a few different pieces to kind of really pick out of there. And you ended on barrier crimes. And I just want to say for individuals who are joining us, who are not aware of the impact of barrier crimes, it's much larger than what we're talking about as it relates to recovery and addiction. But to zero in, it keeps individuals, it's a set of crimes that, are often misdemeanors, just, nonviolent crimes. And when individuals are in active addiction, chances are that, these crimes are related to that. And it can keep individuals with unique experiences, these peers, from working in the systems and areas that they love, as Jimmy mentioned. But it also really dampens the workforce. I mentioned at the top of the hour what we're looking at with the data and where things are trending nationally, but it's also here in Virginia, and we are keeping people on the bench, right? I heard you talk a little bit about, it's time for us to come together and collect. There's no need to keep individuals on the bench. We need everybody who can play a part in this out there fighting. And so, thank you again, everyone, for presenting. I do want to just walk through some of the work that SARRA is doing on the legislative process, and Julie, David, and Jimmy touched on it. And I just want to bring it back together. First, at the top is increasing Medicaid reimbursement rate for peer recovery specialists and family support partners. Also want to, make sure we mention that individuals who, whether it's a family friend, brother, mom, aunt, who are a part of it and want to do the work. Those are family support partners. And we want to increase that so that individuals are paid a living wage, and that organizations like Julie, community service boards, and others can employ them and can bill back to Medicaid. We want to see a limited scope on barrier crimes for individuals who are in recovery from not only substance use disorder, but also mental health. We know the importance of that. We want to see an increased funding for the state comprehensive harm reduction program, which proud to say we've gotten so far. And what it looks like is making sure that we are able to put Narcan out there on the street. We are able to keep individuals alive on Tuesday so that on Thursday we can get them into recovery. And that also includes being able to set up areas in which an individual can come. They can take part in the harm reduction services. That can look like telehealth, being able to connect with resources for housing or other financial resources. And you never know what conversation is going to help an individual on their path to recovery. So we want to make sure that the state is providing funding for that. Additionally, at the top of all of this, we want to make sure we're working with a broad coalition of partners to reform some drug and criminal justice policy. And those have a latent effect. Those have been around for a long time. We heard Jimmy talk about the 90s. I'm not gonna, I'm not gonna date myself, but it's been around. It's been around, and we know the negative impact it has on the field and anybody who is in recovery, who's been in active addiction. And then the last two is we want to establish paid family leave and medical leave so that if an individual is ready for that recovery journey, that we can kind of take some of those worries off the plate. They don't have to worry about losing their job. They know that there's some time for them to go away, or if a caregiver is there, they have the time to take. And lastly, we want to establish a recovery high school out here in Chesterfield County. It'll be the first of its kind, and it's a pilot program. And so with that, once again, we will send out an email with bill numbers and that legislative priority and sort of where those bills are, because we are pretty deep in session. And with that, I just want to open up the door for any questions of myself or of any of the speakers. I think we can do the raise your hand feature, and then Chris can have you on mute.
Can I add one thing before we get there?
Yeah.
Another part of the legislation that VAR was working on this year and supporting was part of that legislation was so when recovery houses, part of the reason recovery houses haven't joined VAR, don't open up in certain places, is because of NIMBY groups and also because of local municipalities and their discriminatory zoning restrictive policies. So part of what we put in there was a protection for certified recovery houses, basically saying that, fair housing laws, we're just reinforcing the fair housing laws, federal fair housing laws supersede state laws, and that we're not subject to, number of unrelated adults in the house. You can't create special barriers and requirements and stuff for recovery housing. We're not licensed group homes. We're not, 3.1 treatment facilities or licensed organizations that we truly operate in the space as a single family dwelling, and you can't put any more burden on us than you would that of an individual family, regardless of whether or not we're related in the house. So that's a huge part of that, because we have seen this in Roanoke, Pulaski, Virginia Beach, Orange County. So it happens all over the state. It happens. We've seen it in Hanover. So what that would essentially do would be eliminate that barrier to us getting recovery houses in some of the places where we just haven't been able to tap into. And part of that is because of community. A lot of people say, it's great what you guys are doing over there, just don't cross the county line, don't come over to our neighborhood and our area with it. So we're trying to work on that as well. Thank you.
No, thank you, David. That's a great point to make. And you mentioned NIMBYism a few times. And for folks who don't know, not in my neighborhood, right? Stigma runs deep. So if anybody has any questions, feel free to unmute yourself and ask away.
Hey, everybody. I just wanted to say thank you to everybody who's on here, and for your efforts, current and previous. I don't know. I've just seen a lot of moving and shaking happening in the last year and a half with the advocacy stuff, and the barrier crimes have directly impacted me. So just I can't put enough of an emphasis on the work that's being done, and the areas that are being attacked to just remove a lot of these barriers for folks that are really working hard trying to get this thing together. And just wanted to thank everybody. Appreciate it.
Thank you, Jason. Jenny, it looks like you have a question. Go ahead and unmute.
I do not have a question. I just have a quick comment about NIMBY. I was former executive director of the Mine Shaft Home in Harrisonburg, and I worked for the Virginia Department of Corrections. And one of the things that I found that it's important that when you go into neighborhoods to try to set up or establish a program, you have to invite the community to the party. You just don't go in and want to have a party in a neighborhood and not invite them to the party. And I found that when I went and talked to the neighbors and talked to people and asked for their input and added them and brought them to the table, I had more success in establishing. I established a female facility and another transition home in a community, a neighborhood, because of that method of inviting people. So I just wanted to share that with the group.
Thank you for that. And I think you make an excellent point. For us to overcome this, it's going to take everybody, and we have to make sure that we are solving these challenges as a community. Mark, you had a comment?
Yeah, I do. Thank you, Victor. And I want to say thank you for hosting this event, and thank you for all of the providers and everyone that is here on the call. And, I was thinking about my own journey, and I was listening to David Rook and Jimmy Christmas both talk about housing and barrier crimes and how it has impacted individuals who have a passion to work in this field, return to school, and all of those types of things that will allow them to be better provider themselves for the population that we are talking about. And my question was similar to how Miss Jenny, she just kind of helped me out with the question I was going to ask, because I got a home, I live in Churchill, and I've been bouncing around the idea of, I'm like, as time progressing, I want to prepare myself for retirement in the next 10, 12 years or so. And I also would like to purchase another home, and I'm thinking, maybe the house that I'm in now could be a place for individuals, look, just like me, who came through a recovery house 20 years ago, so I know the value of recovery housing. VARR was not around during that time, but it was an excellent guy that I got in touch with, who helped me along the way. And I stayed in a recovery house for 18 months. And it provided me with the necessary structure I needed. It helped me to progress, with different goals and journeys that I've been through my life. So, I really am buying into the recovery house process. So, that's something that I would love to provide, whether it's for men or women over here in the Churchill area. And the next comment I wanted to talk about is, how important it is for us to like bond together to help one another who have criminal backgrounds, and, with the laws being changed, my crime itself has been removed. And, I'm really grateful for that. I'm glad that I stayed in and hung in there and didn't recommit, didn't reoffend, because of all of the protective factors that I just spoke about, with recovery housing, making meetings, having individuals in my life who were on the same path that mentored and sponsored me. So yeah, I'm just really grateful for this format, and I look forward to future meetings of this sort. So thank you.
Absolutely. Thank you for sharing, Mark. Definitely sound like a walking testimony. And I'll say, Dave and Jimmy are you guys to reach out to as it relates to establishing a recovery residence. And we'll provide all their info if you don't already have it. But yeah, so that's who you want to talk to. And once again, I just want to thank everyone here who showed up, who listened. And I want to, talk to you a little bit about ways to get involved, right? You heard everyone talking about advocacy, about the General Assembly. Well, this thing is year round, right? It's not just the GA, it's your community, your local community. How do you get involved there? How do you bridge the gap? It's your localities, whether it's city council, supervisors, things along those lines. And that's something, SARRA plays a huge part in being able to help individuals develop those advocacy toolkits. And if you follow any of our advocacy alerts, any of our emails to try to stay up to date, just reach out, stay involved. We think and we believe there's value in storytelling and sharing those experiences the way you did, Mark, the way Jenny, the way Jimmy, Julie, David, and sharing those with decision makers, right? Not just legislators, but anybody, any decision maker. Maybe it's a homeowners association, sharing those stories and how that transformation has occurred. That moves mountains, right? So I just want to, plug that to everyone. Just keep that in mind in how you develop your story, and then follow us. This is going to be one of many events like this. In future, we'll focus in a little bit more on recovery housing. We'll talk about harm reduction. We'll talk about barrier crimes again. And so just stay with us. And that's really all I have. So if anybody has any last questions, I just want to thank you all for showing up. We'll send a follow-up email, as well as we'll have this video up on the site probably by tomorrow.
Hey, good afternoon, everybody. Victor, I'd like to thank you and the SAARA Center for putting this together. I'd like to thank David Rook, Jimmy Christmas, Julie Funkhouser for your presentations. You know, I kind of got a little bit of a twofold question here. You know, as it relates to advocacy, right? Like there's a lot that we do within the communities that can help make our case for us, because at the end of the day, legislators may not care particularly about whether recovery, how much it helps an individual, but some legislators focus on the cost savings aspect, right? The sheer data. And so my question would be to all of you on the panel, how important is data collection? And I don't mean just as organizations, but how important is it for people with community-based assets or people who are licensed providers to really collect data on the effectiveness that their services are having on the individuals with whom they're serving, and ensuring that they're making an investment not only in data collection, but in some studies around that data? Because, you know, I've been told by advocates that came before me that one of the things that we didn't do as a recovery movement early on was make a big investment in data. And we know one group did make a big investment in data back in the 90s, and they've been living off the fruits of that study for quite some time, and it's still recognized. So I just kind of wanted to put that out there, because whether you know it or not, collecting this data as far as the effectiveness of the peer support that we're providing at the community-based level and how that's affecting that individual's life, and making sure that we're using a recognized evidence-based platform or some sort of system or some sort of measurement tool, that helps advocates when they go to the General Assembly. When these advocates like Victor and David and Jimmy and Julie, when they go to the General Assembly, they need that data to be able to show individuals that may not care about recovery, but they do care about the effect that it's having and the overall public health savings that it's causing. So I just kind of wanted to put that out there as a closing thought to the group, and see if anybody has any thoughts. David, Jimmy, Victor, Julie.
Yeah, I'll give it to the panel first, if anybody wants to chime in.
Well, I definitely, so data wasn't just not being collected, it just wasn't available. You know, it just, there wasn't any research, there wasn't a whole lot of, you know, we've done a good job over the last, you know, decade or 2 decades, really, you know, forming a better system, something more professionalized and recognized, you know, in and around peer services. And I think we still got work to do. Victor and I had a conversation recently about, you know, some of the low points around what we do, along with the high points. But I think that the data collection is important. And I think there's, for a number of reasons, for advocacy reasons, you know, absolutely. But also, as the overdose deaths continue to rise and bureaucracy continues to throw money at an already failing system and already failing efforts, you know, we've got to collect data, and we've got to combine data and look at it. You know, which services, which combinations of services are getting the best results? You know, how are we changing lives, and how are we getting there, and what are we using? We already know from certain studies that the longer we can keep someone engaged, you know, Jimmy mentioned, you know, multiple relapses and stuff like that. We know that if we can keep them engaged, we've got a better chance of outcome. And historically, in an addiction treatment thing, it's been 30 days in treatment, and then here's a list of meetings in your local area, hit those up. And I think that we've got to get way past that, and, you know, we've got to start collecting data from that treatment episode through, you know, the recovery support services, the follow-up clinical services and stuff like that. And then I think that we can really make a push for legislative change around regulations and around where the funding gets spent and how it gets spent, and you know, who gets the majority of it. Good question, Anthony.
Yeah, thank you, Anthony, for bringing up such a valuable point. I really don't have too much to add. I mean, both you and Dave, you know, communicated it awesomely. We'll say, you know, the importance of, you know, in all arenas, right? Operating as a treatment provider, advocacy, generating data to report in the advocacy, and, you know, just kind of piggybacking off of what Dave said, the importance of the continuum of care and lengthening the amount of time someone's engaged. You know, I think that it's so incredibly vital. That's what the information is telling us. And so navigating some of these things, like referencing the peer increase, and different things like that will all support the ability to keep someone engaged beyond just, say, a 30-day inpatient, right? So yeah, thank you for bringing up that point and the importance of it. That's all I got.
Yeah, I think it's a fair question, and I just echo what David and Julie said. You need that data, right? I look at it as two parts. You need the stories to sort of change the heart, change the mind, and then you need the data to back it up. And kind of what stuck out about what Anthony said is some conversations I've had, it's just, you're talking to a legislator who may not care, right? It is what it is, who may not care, but what they do care about is the economic impact, right? Oh, we have more people in your district who are able to work and able to spend money in the district. Oh, well, that ear kind of perks up a little bit. So you need that data in order to craft the stories that you need to share with legislators in different areas. And when you go through that process, the difference between a bill passing and not passing sometimes is just that evidence-based data, something they can rely on, right? Something hard, facts, and truthful. And so it is important. And I think, we're coming together and we're having those conversations about what is the best data? How do you track this, right? What are going to be those points? And I think that's part of a larger conversation. And, as I'm looking through to some of the folks on the panel, we have the right people listening. So that's what I really have to say about that. All right. Awesome. Well, I appreciate everyone. Looks like we are at time. And once again, we will record this and we will go ahead and send it out, as well as legislative priorities and information on all the panelists, as well as all of their priority areas. So thank you all. Stay tuned and have a good rest of your afternoon. Bye.